Welcome to the ACP Oncology webinar series. This evening's webinar is delivered jointly with Royal College of Radiologists on the topic of acute oncology. My name is Dr. Daniel Hughes, Chair of the ACP Trainees Committee, and I'll be your co-host this evening alongside Dr. Ruth, Consultant Medical Oncologist at Lancashire Teaching Hospitals NHS Trust. This evening's webinar will provide an overview of where we are with acute oncology, where we're going, and also we'll hear about acute oncology training with a focus on the new curricula for both medical and clinical oncology, and hear about the different models of acute oncology in the UK, as well as multidisciplinary working. The educational content of this evening's meeting are entirely non-promotional, but we are proud to have the webinar series sponsored by Pfizer Limited, world-renowned leader in oncology pharmaceuticals. It is with great pleasure that I introduce our first speaker of the evening, Dr. Ernie Marshall, Consultant Medical Oncologist at the Clatterbridge Cancer Centre, Liverpool, who specialises in both melanoma and lung cancer. Dr. Marshall has been pivotal in the development of acute oncology services locally, but also nationally. He has and continues to help shape what acute oncology looks like in the UK through leadership roles in various national bodies. This evening, he will be providing us with an overview of acute oncology in the UK, where we are currently and where we are headed. So Ernie, when you're ready, over to you. Please go ahead and share your slides.
Thank you very much. National Cancer Strategy is almost entirely focused on planned and elective cancer care. Yet it's interesting that data tells us cancer patients are also particularly concerned with aspects of good access to emergency care. And indeed, cancer patients, more so than many others with comorbidities, are more likely to contact their GP or contact NHS 111 or 999, or indeed have an emergency admission than many other ailments. And consequently, acute oncology is highly relevant to our patients, and acute oncology has certainly come a long way in the past decade. The recent RCR, ACP, and RCP document shows some of the pockets of excellence across the country and some real innovation, but it also highlights that there's limited investment and often rather patchy uptake of acute oncology across the 4 nations. And an important point I'd just like to make is in terms of describing the future, there's no national blueprint for the development of future acute oncology services. And it's very much for us as clinicians to help shape the next decade. If I have the next slide, please. Thank you. So what I'd briefly like to do, if I can, over the next 15 minutes, is describe the origins of acute oncology, some of the problems we started with, a brief summary on where I think we've got to in these last 10 to 12 years, and then the personal view on where we might take acute oncology over the next 10 years. The NCPOD and NCAG reports were pivotal in describing the specific problems of emergency cancer care. These national reports were focused on the entire chemotherapy journey from decision-making onwards, but they were really the first national reports to shine a spotlight on problems with emergency cancer care. Of particularly note for future acute oncology service provision, these reports were entirely focused on inpatient care, and understandably, over 10 years ago, the main focus was on neutropenic sepsis, as this was pre-personalized care and pre-immunotherapy. But the reports did start to highlight that emergency care also impacts on others aside from those with SACT toxicity, and particularly including those who present as an emergency diagnosis of cancer. The reports were also particularly important as they focused the message that the majority of cancer patients sit within general medical beds. And with rising cancer incidence and rising aging and multimorbidity, that's likely to be the situation for the foreseeable future. But really, in summary, what these two reports summarized was this picture of dislocated cancer emergency care, with many patients sat in general medical beds, often in cancer units, and with a lack of oncology visibility. Can I have the next slide, please? The solution, as proposed within the NCAG report of 2009, really suggested a consultant-delivered model of care that would have required considerable expansion in oncology numbers, something that we've not seen over these past 10 years. There was also a very strong focus on the role of oncology visibility within cancer units, and perhaps less so on the need to modernize and improve emergency pathways within cancer centers. And I think it's fair to say there was also a strong focus on the role of oncologists by the bedside in terms of direct clinical care, and perhaps less of an emphasis on service leadership skills and service improvement. However, what the NCAG report also highlighted is that oncologists and acute oncology services have a key stakeholder role in all aspects of emergency cancer admissions, and not simply SAC toxicity, but across a range of emergency and first presentation of cancer through SAC toxicity and including cancer complications that we'll be familiar with. Could I have the next slide, please? So what have we achieved? I've tried to summarize some of the steps that we've taken and some of the problems on this rather busy slide. So we know from quality surveillance measures published a number of years ago, acute oncology is well established, at least across England, with more than 185 teams identified by quality surveillance teams. We've seen an expansion in the delivery of consultant PAs in acute oncology, but particularly there's been a marked rise and emergence of acute oncology nursing. A Macmillan census in 2015 told us that 7% of all cancer nursing jobs were now in acute oncology, and that's likely to improve still further. There's been a number of publications from acute oncology teams that have shown early assessment by specialist teams can reduce hospital length of stay. And we have a national service framework with advice to Alliance service specification published in 2017 and quality surveillance measures both in acute oncology, which were updated also in 2018, and CUP quality surveillance measures from the outset. We also, for the first time, have the national mandated COSD to incorporate acute oncology data fields from this year onwards. And we have the emergence of the NCRI subspecialty research groups in acute oncology and CUP services. But it's fair to say there's still many problems. Whilst services have been established, they're patchy, there's been limited investment, it's a different picture across the 4 nations, and many teams are only able to deliver 5-day services. There's also been considerable progress in cancer centres, but perhaps an element of disengagement at the acute hospital level. Whilst consultant PAs have increased, they are spread thinly across job plans, and as the poll highlighted, many consultants have a role in acute oncology as part of their generic on-call provision, rather than subspecialist leadership roles or direct clinical care within acute oncology units. And there's a relative sparsity of defined roles and responsibilities for consultants who deliver acute oncology. Nursing has improved, but oncology engagement is perhaps not as good as it was. And many units which are thriving on the basis of nurse-led delivered acute oncology services that continue to require oncology leadership and visibility. We may have reduced length of stay in some aspects, in some hospitals, but that has had no impact on admissions. Admissions for cancer patients are rising, and there's a significant minority of patients who have long stay within our hospitals. Quality surveillance is embedded, but doesn't appear to be a strong lever for commissioning. And whilst we have some progress in national data collection, currently Acute Oncology has no visible national data set and a very limited research portfolio. Could I have the next slide, please? I also wanted to highlight that the true size of unplanned cancer care is perhaps much bigger than our traditional hospital-facing acute oncology services that have evolved. And I show some data here from a recent 2-year project across Merseyside and Cheshire that attempted to measure the size of unplanned care across the system. And what this report highlighted is more than 10% of paramedic activity concerns cancer patients. And in the world of paramedic care, 60% of cancer patients are conveyed to hospital, a much higher conveyance rate than we see with other comorbidities. Cancer accounts for 5% of emergency department presentations, yet 15% of admissions. And looked at a slightly different way, 80% of cancer patients are admitted from an ED presentation, as opposed to 25% of non-cancer. And across this time frame, nearly a third of chemotherapy patients were presenting or were admitted via an ED route during their treatment. Could I have the next slide, please? So despite some of the progress we've made in acute oncology in the Merseyside and Cheshire area, this report highlighted a number of concerning problems that were perhaps familiar from the NC-POD report and suggest there's much more work for us to do. And some of the key findings were this lack of confidence in managing cancer patients at all levels of urgent care, whether that be GP, paramedics, ED departments. There was a greater likelihood of conveying the patient to the next step and leading to admission. Some of that represented complexity of care, but some of that was lack of information, lack of confidence in managing cancer patients, often on complex treatment pathways. And in addition, a significant proportion of patients who were admitted for less than 72 hours, who perhaps could be ambulated with more joined up care. The report also highlighted ongoing poor patient experience in the emergency pathway, but also poor professional experience for those urgent care clinicians involved. There was a significant number of avoidable emergency department presentations and admissions, often because of a lack of alternatives at a network level to ED, some of which was impacted by that general lack of education and training across the acute care pathway. It was also notable that there are blind spots and that acute oncology activity does not appear on the urgent care radar as a consequence of unreliable coding and an inability to identify cancer patients in the urgent care system. In Merseyside and Cheshire, we've had significant progress in AO delivery of CUP services, but in many hospitals, there remains no formal 2-week referral pathway to enable these patients to access an LPD appointment and outpatient MUO diagnostics. Next slide, please. So we've made great progress, but there are a great number of problems still ahead of us. And in looking forward, if acute oncology is to remain relevant to the system, it's critical that our future AO service provision understands the changing world of health services across the UK. And that acute oncology is not simply hospital focused, but increasingly able to support the wider urgent care system. And it's important for oncology services that they have a wider understanding of transformation work that's happening across the UK, including transformation of urgent care, our cancer transformation programs, and the long-term plan. In cancer, we'll be familiar with the emergence of novel therapies, personalized care, immunotherapies, and cancer patients who are surviving longer than they have been ever done before. But acute oncology services also need to find a mechanism to support the drive to reduce emergency presentation of cancer, and how we might identify and prevent some of these admissions. Acute oncology teams will be familiar with the subsets of patients who often find themselves in hospital: lung cancer patients, breast cancer patients on chemotherapy, and we need to find mechanisms to perhaps risk stratify such patients and identify them and manage them more proactively before they arrive in hospital. The urgent care transformation programme is increasingly being driven by improvements in advice and guidance, underpinned by a renewed NHS 111. And we need to understand how NHS 111 transformation links with cancer helplines. We also need to understand how acute oncology and support for cancer patients can be built into the wider system of urgent care, including community response teams, our paramedic colleagues, the role of urgent treatment centres, the role of ambulatory medicine. And within the long-term plan, we need to recognise the push towards developing out-of-hospital care and how digital systems will enable improved care over the coming years. We clearly need to understand the impact on COVID and recovery, and how virtual working will help in cancer management underpinned by acute oncology services moving forward. Next slide, please. So whilst there are many challenges, there are also a number of unique opportunities that will support the future development of acute oncology. The RCR-RCP document I alluded to at the beginning highlights some of the benefits and the progress, but it places a key emphasis on the need to develop acute oncology as a subspecialty with equity alongside our site-specific colleagues and services, and a key role in developing leadership and future acute oncologists with respect to training. The NHS has a key priority to develop same-day emergency care provision and to transform NHS 111, and cancer needs to be part of that work stream. Cancer services have a real focus in the next few years on the role of rapid diagnostic centres, and we need to understand the AO interface in supporting upfront cancer diagnostics for more difficult subgroups such as our CUP patients. We also need to understand how to work alongside our subspecialty colleagues, particularly in the evolving role of enhanced supportive care, the role of acute medicine and ambulatory medicine, the role of frailty and oncogeriatrics, as well as holding our site-specific teams to account in terms of the emergency admission burden we see within the hospitals. The post-COVID digital change will drive an emphasis towards telehealth, home monitoring, virtual ward rounds, and a much greater opportunity for virtual acute oncology to support a more networked approach to cancer care. We also need to be cognizant of the changing commissioning landscape and the evolution of primary care networks and integrated care systems, which may enable us to place acute oncology within a stronger locally commissioned and place-based commissioning picture. And finally, to bring all of these things together, we're hoping to launch a new UK-wide Acute Oncology Society and website later in the year to help galvanise and maintain the momentum about some of these changes. Next slide, please. So in conclusion, I think the future of acute oncology is bright, but clinicians need to help us shape the direction of travel. We need to move acute oncology towards the front door and beyond, and reach out into community. We need acute oncology to be much more visible to the wider urgent care system in terms of our data, our performance, and our evidence base. And to deliver all of these above, we need acute oncology to develop and deliver stronger leadership at every level, both in terms of consultant colleagues who are delivering acute oncology now, but also in terms of our future consultant colleagues and our training.
Thanks, Ernie. I'll just introduce myself to everybody before we move on to questions. So I'm Ruth Board. I'm a consultant medical oncologist at Lancashire Teaching Hospitals. I started in around 2011, setting up the acute oncology service at Preston and Chorley, and coincidentally also do melanoma and lung cancer, but that's not a requirement of somebody who's to be interested in acute oncology. Ernie, just a few questions. One from the audience about whether or not there's an alternative for patients to going to the general emergency department. So are there sort of specific emergency departments for cancer patients?
Yeah, I think as a nation, we need to kind of offer a whole spectrum, don't we? Within our cancer centres, and within some of the larger hospitals, we need to develop cancer-specific ambulatory pathways, and I'm sure we'll hear about some of those later in the talk. But outside of those units, I think acute oncology and oncologists need to work much more closely with our acute medical colleagues and that wider urgent care system I mentioned. There's opportunities for patients to be directed to paramedic care, to urgent treatment centres, to ambulatory medicine units. And we need to find a mechanism to enable those teams to deliver frontline cancer care with the support of oncology and acute oncology services. So I think we've got a requirement for both of those things, cancer specific, but also alignment with general acute medicine and the rest of the urgent care colleagues.
Thanks. And I guess one of the frustrations over the last 10 years has been how can we engage the commissioners, policymakers, how can we best get them to understand how important an acute oncology service is for the patients and the wider healthcare system. And I know that you've had your own frustrations with Nhs England around this. So have you learned anything that you can share with us, or any tips about what we could do?
I guess you have to keep going. You have to be resilient. You have to keep saying the same message. But I think the opportunity is around having a seat at the table. And at the moment, acute oncology can be a slightly siloed service within cancer, whereas what we need is a chair at the table of urgent care commissioning, because the NHS as a whole is moving towards admission avoidance and ambulatory medicine. It wants to hear how we can help from a cancer specialist perspective. So we need data, we need performance and quality measures that work, but more than anything, we need oncologists and we need acute oncology services at the table with our urgent care colleagues to show how much cancer impacts on the wider urgent care and how we can help support some of those changes in service.
Yeah, and obviously, as we know, the increasing number of cancer patients coming through the oncology clinics and not enough oncologists to see them. So how can we balance that dynamic between providing an acute oncology service but still needing to see all the site-specific patients that are coming through needing treatment?
I guess we need to keep growing oncology. We've got every reason to catch up with our European and international colleagues in terms of numbers per population. But more than anything, I think we need to be part of a wider team approach, working with our geriatrician colleagues, our specialist palliative care colleagues, our acute medical colleagues, our nursing colleagues. And I think we'll only get that by delivering this as a system offer where we're all taking part. It's not for oncologists to do all of this, but I think oncologists have got an absolutely critical leadership role.
And I'll just read a question from the chat, Ernie, about that some consultant colleagues feel that, I think what they're saying is the role of acute oncology is for acute oncology to finish diagnosing the patients that are inpatients, and how do you address that dynamic? And I guess there's the problem that you might just be everybody's registrar if you're an acute oncology consultant.
You know, I think the opportunity and the breadth of acute oncology is enormous. You know, we touched earlier on the slides about a role in emergency late presentation, the role in SAC toxicity, the role in complications. I think there's some really important work happening around cancer diagnostics and the RDCs. It might not be for acute oncology to deliver those, but we have to be key stakeholders. And what those services require is expert leadership around ceiling of care and specific cancer diagnostics. It doesn't mean acute oncologists need to deliver those things, but we have to support their growth and their development. So there's great examples in Guy's, acute oncology leading on RDC development and you know, developing those skills around cancer diagnostics. But there's huge amounts of opportunity in research about immunotherapy, toxicity management, and cancer-specific ambulatory units. So there's lots to do out there, and there's lots of service improvement research opportunity, which means it's much more than just picking up the pieces on the shop floor, I think.
So it's with great pleasure I now introduce our second part of the evening's webinar, which will focus on training in acute oncology and the new curriculum. This section will be jointly delivered by Dr. Rachel Cooper, Director of Medical Education at the Royal College of Radiologists and Consultant Clinical Oncologist at Leeds Cancer Centre, and Dr. Anna Olsen-Brown, Medical Oncology Trainee at Clatterbridge, Liverpool, as well as Trainee Representative on the JRCPTB Specialty Advisory Committee. So Rachel, over to you when you're ready. You can start sharing your slides.
Thank you, Dan, and thank you to the ACP for inviting me from the Royal College of Radiologists. This evening, myself and Anna would like to talk through the new oncology curriculum, particularly with respect to acute oncology. And really excellent talk from Ernie, which I think really sets the scene for us in terms of the curriculum. I did notice though, Ernie, on one of your opportunity slides, you'd not put the curriculum on. And I think the curriculum really is a great opportunity for driving some of the changes that you talked about in your slides with respect to acute oncology, particularly the ability to build and lead acute oncology teams, and giving new consultants, our trainees who then become our consultant colleagues, that confidence to be able to manage acute oncology, both at the individual patient level, but more importantly at the team and system level. So as Dan said, I'm a consultant clinical oncologist in Leeds, but I'm also the Medical Director of Education and Training at the RCR for the next couple of years. And many of you will know Anna, who's an ST6 medical oncology trainee in Liverpool. And Anna is involved in too many things for me to list, very active trainee. So the drivers for change came from the GMC, and it wasn't just the clinical oncology and medical oncology curricula, it was all curricula. And this came from really three sources. The first one was the Excellence by Design, which was standards for postgraduate curricula. And the GMC wanted specialties to change their curricula and look at more high level outcomes, so that we were thinking about what a trainee would look like when they'd finished their training in terms of their capability before becoming a new consultant. So it was moving away from a list of to-do things into a much more holistic approach to training, which I think is more appropriate and fits much better with training than certainly the curriculum we had at the RCR, which was very difficult to use and I suspect was very rarely looked at. The second aspect came from Shape of Training, and just to remind some of you, because this is an older document, the Shape of Training report was looking at particularly the ageing population and about the holistic management of the individual rather than the super specialised management, and the balance between specialism and generalism. And the Shape of Training report also recognised something that Ernie alluded to, in particular, the increasing demand of the acute, unselected, unscheduled admission of patients, which is starting to drown out the acute medicine and the general medicine service. And we know that these are also specialties that are increasingly difficult to recruit into. So, as highlighted by Ernie, the GMC were really highlighting those areas where we know there are problems, and that was one of the driving forces for including acute oncology within the curriculum. There was also a requirement for more flexibility within training, so that there was more ability for trainees to move between the two specialties, as well as recognising some common areas of training. So what are the key changes? So there's close alignment of clinical oncology and medical oncology, and the Clinical Oncology Curriculum Committee and the Medical Oncology Specialist Advisory Committee, SAC, worked very closely together over a number of years to develop the curriculum and align the two curricula very carefully together. And as mentioned, they were challenged by the GMC COG, the Curriculum Oversight Group, to a number of features. One was to increase flexibility. One was to recognise common areas of training, greater support for acute unscheduled takes, so greater support for acute oncology, and a more holistic assessment of the trainee. So the training pathway will be very familiar to you, but there are some key changes. Trainees will come in having done at least the foundation year and 2 years of internal medicine, having gained MRCP, and that's common to both specialties. If trainees do an additional year, that's not detrimental, that's completely flexible. They'll go through selection into either clinical oncology or medical oncology, as we do now, but the first ST3 year will be known as the Oncology Common STEM year. And medical and clinical oncology trainees will work very closely together following the same curriculum. During that first year, the focus is on developing generic and core oncology capabilities with less focus on the specialist medical oncology and clinical oncology capabilities. At the end of the first year, they will have an identical ARCP grid for the different specialities, and then they will peel off into the different specialties, with clinical oncology having a further 4 years and medical oncology a further 3 years. Although, as many of you know, there's a real drive to move towards assessment by capability rather than purely by time. This means that there is some flexibility with the Oncology Common STEM years, that if a trainee decides they wanted to switch specialties after 1 year, whilst they'd still need to go through the same recruitment process, that first year would still count. And that met with the requirements of the GMC. So the curricular structure is based on a smaller number of higher level learning outcomes, which are called capabilities in practice. And beneath these capabilities in practice, there are also descriptors, which I'll talk about in a moment in relation to acute oncology. We need to remember that these are exit outcomes. So we don't expect every capability to be achieved to the highest level within those early years of training. And different trainees will gain these capabilities at different rates due to personal circumstances and different opportunities in their training. So they describe for us what we want a trainee to be able to do, what we want them to be capable of once they gain their CCT and become a consultant. In the curriculum, the outcomes have been, as I said, been called capabilities in practice, and they're divided into 3 groups. So the generic ones, and they're common to all physician specialities. So they're around about communication, team working, the NHS structure. There are then some shared oncology SIPs, which we've developed jointly, and that's where acute oncology comes in. And then there are specific ones to both clinical oncology and medical oncology. So, for example, in medical oncology, as you can imagine, many of those are specifically related to radiotherapy. So this is the Acute Oncology SIP, and as you can see at the top, sorry, just go back again. As you can see at the top, we have the higher level outcome for acute oncology. So this is about being able to deliver the acute oncology take, being able to manage patients with acute oncology problems, being able to communicate and work with different healthcare professions. So that was something that Ernie really brought out, being able to work with the acute medics or where patients coming in to the service or out in the community. So beneath that high level outcome, you will see there are some descriptors. And what these descriptors do is they define the underlying skills. So they provide a guidance to both trainees and trainers about the range and the clinical context which the trainee needs to achieve in able to support that SIP. These descriptors are not intended to be the prescriptive or exhaustive, but they're to give some kind of framework and guidance for the trainees and trainers so that they know that they are working towards that higher level SIP. They're also associated with some suggested evidence, as you can see beneath, and we'll talk about that a little bit more later on. And also, extremely importantly, they map to the GCPs, and that was another area that the GMC were very stringent about, that we had to map the curriculum to general professional capabilities, GCPs. So assessing SIPs, by assessing a trainee's progress against one of the SIPs, we're automatically assessing their underlying skills and capabilities, and that allows them, their experience, that allows them to perform the task. So what we're saying is if they can be entrusted to perform the task independently, then they must also be competent in the underlying skills. And this allows us to streamline assessment by looking at a number of competencies in one go, rather than having this approach of having a sort of tick list of being able to do X, Y, and Z. And importantly, if the trainee is not yet capable of performing the SIP independently, we can look at those descriptors and we can drill down into each of the underlying competencies that are still missing. And then we can focus feedback and additional training into those areas. And in that way, the model allows the trainee with their trainer to build up their capabilities within each particular SIP. So that would apply for acute oncology. And that allows us then to develop the assessment of the SIP through entrustment scales. And this is just a really simple way, it's quite intuitive, of saying where the trainee is in their ability to deliver that SIP. So beginning of their training, they'll obviously all be on a level 1, which is entrusted to observe only. And then as they progress through their training, their ability will increase until they get to the point where they can act unsupervised and are working at the level of a consultant. And for acute oncology, by the end of their first year, so the OCS year, we would expect trainees to be working across that acute oncology SIP at level 3. So that's entrusted to act with indirect or minimal supervision. And to put that in your head as to what that feels like, that would be that the doctor, the consultant, or their supervisor might not be physically in the hospital, but they would be easily available for consultational discussion about patient care. So that's just to emphasize there, if you look, acute oncology is SIP 8, and that's the full SIP. And as you can see in the OCS year, that's at level 3. You'll also notice that across the training, up until the final year, and this is obviously the clinical oncology grid, but the medical oncology grid is the same. So that would be at the ST6 level, and they're not expected to reach that level 4 until the very end of the training. So why might that be? Well, the first thing to say is that acute oncology is not just about the OCS year, and this is a really important message that we want to get over. And I think there's been some initial confusion about this, particularly as we're expecting trainees to attain quite a high level for acute oncology in that first year. But this is about training in acute oncology throughout the training, and that's really, really important. And that's because it's not just about that ability to manage patients, but it's about preparing trainees to shape and run acute oncology services. So reach that next higher level that Ernie was describing so eloquently. Furthermore, the acute oncology SIP does meet the shape of training requirements by supporting the acute unscheduled care. But as Ernie said, acute oncology, and as we will hear later on in the meeting, is delivered in many different ways throughout the UK. And so the acute oncology within the curriculum is not prescriptive, it's very flexible, and therefore it reflects how acute oncology is delivered locally. And myself, Louise Leon-Andrews, have visited many clinical oncology and medical oncology training programs where we've discussed how individual training programs or individual hospitals might deliver this training in acute oncology. And as I emphasised before, the entrustment level applies to the whole SIP. And importantly, the acute oncology SIP provides at the end the ability of trainees to manage the acute oncology service. And that's something that we would only be expecting them to do independently at the end of their training. But this fits in very nicely with some of the themes that Ernie was trying to bring out. So what specifically is within the curriculum to guide you as to what trainees should be doing alongside the SIP? So the three areas that we've already heard about: the acutely unwell patient with suspected new cancer diagnosis that might be coming in through ED or through the AMU. So the ability to investigate, investigating of imaging that suggests cancer, identification of a primary site for those with metastases, and management of metastases in patients with CUP or MUO. The second area is the management of the acutely unwell patient who's currently receiving SAC and or radiotherapy, and that's particularly a management of the immunocompromised with an infection, increasingly important immunotherapy toxicity, and then rarer aspects of acute oncology such as tumor lysis syndrome. And the third group would be the acutely unwell patient who may be suffering from the complications of the cancer rather than the treatment. So we're very much aware of those patients with cord compression. Pain is a particularly difficult area, metabolic disorders as well, VTE, paraneoplastic syndrome, seizures, reduced GCS. So that whole range of complications related to the cancer. And obviously in this area particularly we would be working very closely with our palliative care colleagues as well. With respect to supervision and how do these trainees know that they're gaining the structured training with the clear educational objectives? Well, trainees can be assessed and supervised by any member of the acute oncology team, and that doesn't necessarily mean it will be a clinical or medical oncology consultant, because we know that in some smaller cancer units, for example, the acute oncology may be run by an acute physician, may be very much clinical nurse-led as well. So the requirement is for those people to have been properly trained, and they are then able to assess and supervise trainees in following the curriculum. However, the important point is that it must involve structured training. So there must be clear educational objectives that relate back to the capability in practice in acute oncology with those descriptors underneath it, so that we know that our trainees are getting the right training. There must be effective feedback, and there must be an opportunity to develop. And that's why we've said that being on call is not sufficient to reach that higher level capabilities within the acute oncology aspect of the curriculum. It may form part of it, but on its own it's not sufficient, and that's what some of the training programs have been struggling with a little bit. In terms of what assessments are required, again, suggested evidence is included in both curricula, and perhaps for acute oncology in particular, case-based discussions and the ACAT will be evidence that will probably be really quite important for this. And you can also imagine the MSF would be quite useful as well, because there's a huge amount of communication required in acute oncology. In terms of ward-based assessment, as you know, it's a programme of assessments, and these have been revised to match the new curricula. With the OCS, there's been rationalisation of the assessment tools across the two specialities, but the overall burden of ward-based assessments in both curricula has not been substantially changed. There are some new tools, the acute care assessment tool, which I mentioned may be very appropriate for acute oncology. New for clinical oncology is the multiple consultant report, although many of us are familiar with this from IMT and other specialties. And then there are some new ones for medical oncology, the DOST and DORPS, which assess systemic and radiotherapy respectively, and perhaps less related to acute oncology, although of course you can see how these may come in, particularly the DORPS for, say, a cord compression. So finally, when is this curriculum coming to us? Most of you, I hope, will now be aware that all of the new trainees that were recruited in this last round, including the 50 new places that we have across clinical and medical oncology, will start on the new curriculum in August, September of this year. Current trainees will transition to the new curriculum after their ARCP, unless they are due to CCT within 1 calendar year. It's been recognised that this may have some impact on less than full-time trainees, so the GMC, following pressure from colleges such as the RCP and the RCR, are looking at whether there may be some flexibility around that. But this is very near, it's very new, and I know that in most training programmes, both across clinical and medical oncology, there are quite advanced plans as to how they're going to implement both the OCS year and, importantly, the acute oncology training, so that we can achieve what we want the curriculum to achieve in terms of training our future consultants in acute oncology.
Thanks. Rachel, can I just ask a few questions before Anna talks? But there was, I think Francis might have covered this in the chat, but I think it's an important point around when the clinical oncology trainees would be expected to do their FRCR Part 1.
Well, we'd still be expecting them to do the FRCR Part 1 at the end of their ST3 going into ST4 years. So the intention is that they would still follow the basic science course that would enable them to pass the exam. But we're also anticipating that the medical oncology trainees will also follow that course, because at the end of that first OCS year, it's important that both trainees, all trainees in oncology, because I prefer to call them oncology trainees, have achieved and have experienced and have the same opportunities in training, because the whole idea is that that year should just be seamless between the two specialties. So if they want to swap, that whole year will count, and that's really, really important.
And another question about trainees that are maybe, you know, a couple of years into their training already, who I guess maybe more for the medical oncology trainees who may not have gone through the radiotherapy planning observations, etc., that the trainees coming through now will pick up in their first year. What's the expectation for some of those trainees if they're moved onto the new curriculum? How do they sort of play catch up, if you like, if all they've done is on call in the past, for example?
Yeah, so there are some tools that both the RCR and the RCP have developed in terms of migrating between the two curriculum. So we're not expecting trainees who are already established in their training to go back and try and match up what they've done and what they haven't done. In terms of things like DORPS, Ruth, off the top of my head, I can't tell you what the requirements are later on in their training, but I think that, you know, there are some opportunities for people to pick those up, mainly through things like acute oncology. And for medical oncologists, they're fairly low level in terms of, you know, being able to maybe plan a patient for a cord compression, which obviously is then very useful for people, for medical oncologists, in the same way it's very useful for us to understand some of the more you know, some of the SAC that we perhaps not so used to giving in clinical oncology. But it definitely, you don't need to go back and start trying to match this with this. There is a way that you can very seamlessly migrate from one curriculum to the next.
Yeah, so there's a question there about if you did want to switch. Now, my understanding is that year would count, but you still have to, have to reapply to switch. Is that right?
Unfortunately, it's not as flexible as perhaps we would like, because basically that year counts, but you have to go back through recruitment. And so, of course, there's no guarantee that you would get a number in the same hospital or department. So in reality, I'm not sure how much that flexibility is there and people will use it. But we do know that there are some trainees who decide they're in the wrong specialty.
Absolutely. Anna, can I bring you in? What, as far as you can tell, what's the feeling within the registrars about the changes to the curriculum, and what are the main concerns?
I think that there's two distinct sets of concerns, well, not concerns, but just considerations depending on where you are in your training. So, and then there's a specific group of trainees that I think are a little worried about how this transition is going to affect them. So I think the people that are currently in training, who have obviously done a lot of talking about a change in curriculum, they've been aware that the curriculum changes are coming. I think that the transition from the current 2017 curriculum onto this curriculum is causing just a little bit of concern about how smooth that will be. And I think that's partly related to the fact that there are some different challenges. I think people are quite concerned about the radiotherapy side of it. I think it's worth there's not really a need to be, I don't think, from a med-onc perspective, because actually the requirements are basically to have an awareness of how radiotherapy is used and where it fits in treatment plans. So I think, referencing back to the question about if they haven't done the OCS year, where will they get their radiotherapy experience from? So they will still, people in medical oncology training posts will still be expected to be able to demonstrate that at their CCT point, because that is in reality where it's assessed rather than at the end of the first year. But it's relatively easy to show, and actually it's stuff that we do see already. It's about being aware of the spinal cord compression management pathways. It's about being aware of where radiotherapy fits in the tumour specific management of patients. All stuff that we're doing, we're just not necessarily evidencing, and I think that's the difference. And I think it will be relatively easy for trainees to be able to fulfil those sort of experiential learning points. Part of the reason we were keen to have the DOPS and the DORPS forms brought in is we did a survey of medical oncology trainees who very much clearly said, actually, we don't have discrete teaching in a couple of areas. And one of those was about pharmacology and SACT and how that could be more robust. And the fact that also that we don't have any sort of radiotherapy tools. So the DOS and the DORPS forms shouldn't be considered to be scary at all. They're just basically a slightly more specific structure that will allow trainees to know where they've got to go with their assessment. So it's not a concern at all, really, and it's something that I think people get used to using relatively easy. So it's just a bit more of a sort of a structure. I think trainees that are starting on this year, it's more about, they seem to be expected to do lots of things in the first year, and we only really talk about the first year. So I think it's about, again, as Rachel said in her presentation, the understanding that those sort of experiences are throughout training, and the OCS year is really just sort of a meeting of minds in the sort of the experiences you can get in the first year. But it is sort of it's more like a spiral throughout training. I think the other group of trainees that we have to be really mindful of are people who are training less than full time, because obviously it can be more confusing working out what you've done where. And I think moving towards a sort of a competency based platform will be easy to understand for the majority. But I think there is that group that we just need to really give enough support to try and work out where they are up to in training and how this affects them.
Yeah, and I think just on the radiotherapy, Ruth, as Anna said, I think intuitively you're picking that up anyway. I mean, I think if you sit in any MDT, you're going to have a clinical oncologist there who's going to be talking about radiotherapy and where it fits into any pathway. So you'll be very familiar with that and those discussions as well. So I think that will be relatively easy to pick up.
Yeah, I mean, I'm obviously very supportive of that as part of our training. Right, I did a number of clinics with clinical oncologists, and I think it really helps get that sort of rounded experience. So just another question from the audience about, I guess this is if you've you're not a new trainee, about whether or not you need to do a formal rotation in acute oncology to get level 4 competency near the end of your training. But I don't think it's quite that black and white. Is that right?
No, I think you should be talking to your TPDs or your heads of training about their plans for acute oncology, because as we keep emphasising, there should be plans that not only affect or not only develop for the ST3 year, but are actually throughout the training. So I think as you become more mature as a trainee, you'll be naturally doing these sorts of things anyway, in terms of making decisions in clinic, talking to allied professionals about managing patients and patient pathways. So I think you should naturally gain those skills, so that by the time you come to your final year, you are able to do that. And I think that's a much better way of gaining those acute oncology skills than having some kind of, I don't know, 3-month block or something in your last year in acute oncology. Because to me, that's not what acute oncology is about, actually. I think what we're trying to do is embed acute oncology into everybody's mind and everybody's job plan. I think it's everybody's responsibility, and it might be more of some people's responsibilities with their PAs, but the whole point of the curriculum is that it's really embedded in your DNA. So in the same way as you intuitively know how to manage neutropenic sepsis, you would also intuitively know how to manage all of the other things around acute oncology.
Yeah, Anna, do you want to comment on that?
Yeah, so I do agree with that, and I think absolutely over time, as the curriculum becomes embedded, that will happen naturally as the people who start in the OCS year progress through. It will become something that, again, is that sort of spiral re-exposure. But I think we have to be sort of the desires and the outline requirements in the curriculum are very flexible. There are some things that there needs to be some signpost time. So it doesn't need to be a block of acute oncology time that you only do once in your training, but it does need to be hallmarked time that is acute oncology experience time. So there's always this discussion about would an on-call be sufficient to be your acute oncology training, and it isn't enough. And the reason is that actually there isn't that feedback process that you go through, that isn't that sort of relationship and leadership and skills building with acute oncology teams and in reach into other hospitals or other areas outside the cancer unit or cancer centre. So it is very flexible, and you can, and if you know, and at the moment you can sort of hallmark an acute oncology experience very flexibly. But I think there should be an aspiration, and the aspiration within the ACP RCP document is that you do have some specific set aside acute oncology time, because that's actually where you gain the skills from your peers and from your colleagues, both medical and nursing colleagues. So it's flexible in terms of fulfilling the requirements. And I think Rachel's absolutely right about sitting down and talking to your TPD and your educational supervisors about how your region is planning on developing this. But I think you have to be able to, at the end of it, say, I did acute oncology in these areas, and this is how I gained my competency. So it is about just being a bit more aware of the fact that there's a requirement there, rather than just picking it up as you go along. So it's subtle but important.
And can you remind me, does the curriculum specify whether that has to be within a trust that has unselected take?
No, it doesn't specify that. So because of the fact that some trainees just simply don't go to those trusts. So it absolutely doesn't have to be that. And if you're in a setting where you'll do an oncology take and then you'll do a post-take ward round and a learning experience after that, then that would be considered to be sufficient. But just answering calls on the phone or an on-call take wouldn't be, because you wouldn't gain those skills. But you don't have to be in a hospital that does an acute unselected take. There's an argument that actually spending some time in a setting that does have that and some time in a setting that doesn't actually probably makes you a more well-rounded acute oncology trainee.
Agree. I think there's something about seeing a patient with a new diagnosis of cancer straight at the front door before biopsy that is a real learning curve. And can I ask you both, how obviously the curriculum has come in almost at the same time that the junior doctors have been applying for their posts. So do you think this is going to be a bit of a shock for the new STs, that It's not all about the physics of radiotherapy and the minutiae of phase 1 studies, and actually there's much more general medicine within oncology than perhaps has been traditional.
Certainly from the oncology want to be oncology trainees that I've spoken to, there's been quite a lot of awareness about the fact that this changed. I think it's worth remembering that these trainees are the trainees that have been through IMT. They're aware of shape of training. They're aware of the changes that in training more broadly. You know, actually, as it stands, they're the first people that have done IMT training as well. So, you know, they're a group that have been through a lot of change already, which is both a good and a bad thing. You know, but I think they are aware of the fact that there is that desire for generalism, and actually generalism within an oncology setting is actually I think most people are sort of aware and actually quite looking forward to it. I think that flexibility between understanding a little bit more about both of the specialties is quite useful, but they still, certainly the groups that I've been speaking to, they still very much sort of identify themselves as a clinical oncologist or a medical oncologist. So I don't think it will come as a surprise. I think it will be a learning experience for all of us to work out how to deliver that over time. And I'm not sure this year will be the year, you know, I'm not sure how we do it this year will necessarily be how we deliver it going forward. I think it's got to embed and it's got to sort of ruminate a little bit, and we've got to support those trainees whilst they're going through that experience, because ultimately it's their training at the same time.
Yeah, I would totally agree with you. And I think, you know, the issue we have when we have patients come in with an acute oncology problem is that they also come in with multiple other ones as well, don't they, Ruth? And I think that's sometimes what is very difficult, particularly for older consultants like me, to manage. And I think our trainees are absolutely brilliant at managing that kind of holistic picture of the patient. And I'm always very, very impressed and grateful to them for doing that. I just want to address one question which keeps coming up, that people keep asking about, you know, does the new curriculum detract from higher level radiotherapy skills? And it does not detract from higher level radiotherapy skills. Those higher level radiotherapy skills in the clinical oncology aspects of those SIPs are all in there. There's interpretation of radiology, there is volume definition, there is brachytherapy, there's radioisotopes. They're all in there, and it does not detract from that at all. But we have to remember that our profession, you know, as we become clinical oncologists, is just not about delivering you know, high level specific radiotherapy. It's about managing the whole patient as well. So it's skilling everybody to be able to do all aspects of clinical oncology, as Anna, I'm sure, will agree, the same for medical oncology.
Yeah, so I realise we're getting short time, but I do agree. And I think one of the things that's really important for everybody to be aware of is when we were developing the curriculum, there are generic SIPs, there are joint oncology SIPs, and then there are medical oncology SIPs and clinical oncology SIPs. So we haven't lost that depth and granularity of experience within each of the individual specialties. And actually, I think we spent a long time actually considering what they were and how we better define those so that we don't lose those skills. So it's very much part of the central consideration when we were putting the curriculum together, that we would very much maintain those specialty specific skills that we've come to need.
Yeah, I think the curriculum sort of defined what we all do the same and do really well together, exactly. But equally has actually defined the difference between medical and clinical oncology. So I'm just going to hand back over to Dan, and if there are more questions on the curriculum or specific questions for Rachel and Anna, if you keep putting those in the chat, and then after we've had the presentations on some examples of acute oncology, then we can pick those up in the panel discussion at the end.
Thanks, Ruth. Thanks, Rachel and Anna, for a really great talk. So in this next section of the webinar, we'll be hearing from experiences and different perspectives from across the UK. So firstly, I'm pleased to introduce Dr. Andy Viggers, trainee clinical oncologist, as well as Dr. Rob Turner, consultant clinical oncologist, both from Leeds Cancer Centre. They'll be presenting their experience of acute oncology in a specialist cancer centre before we hear from talks about the District General Hospital and multidisciplinary working. So Andy, when you're ready, over to you.
Thanks very much for inviting me along to talk this evening. And as you say, I'm joined by Dr. Rob Turner, one of our consultants in Leeds as well. And we were asked to sort of give a brief overview of what acute oncology in a specialist cancer centre can look like. So going to be sharing the sort of the Leeds Cancer Centre experience. So we're going to just aim to quickly sort of outline our model of care, some of the challenges we face, and also then trying to improve that trainee experience, as we've just heard with the new curriculum as well. So our model is sort of, if we divide the patients into those sort of type 1 versus the type 2 and type 3 patients. So the type 1 patients who are presented with new malignancy as an inpatient or in an acute care setting. In Leeds, we have a dedicated in-reach malignancy of unknown origin team who also have an outpatient setup as well. So they are able to both meet patients as an inpatient, but continue to follow them up as an outpatient as well, which improves being able to ambulate patients rather than keeping them in for the full course of their investigations. We have an increasing expectation within Leeds at the moment that sort of those patients are potentially moving across to the oncology bed base to help support our acute medicine colleagues, particularly in the midst of COVID, but also in line with sort of the changes in the sort of acute oncology delivery and the curriculum changes. And we in Leeds have sort of 40 to 50 patients that are being tracked by our malignancy of unknown primary team at any one time that are moving through that diagnostic pathway. So it's a reasonably big service now, and you know, may continue to grow as we're able to potentially investigate and treat more patients as newer treatments are coming through in the future. And then for our sort of other patients who have a known cancer but are presenting with either an acute toxicity of their treatment or a complication of their cancer itself, these patients are all seen in Leeds on a dedicated assessment unit. So at the moment, that's an 8-bedded unit with some consultation room space as well. So some of those are inside rooms, some of those are trolley bays. And even then, we're finding that our space is increasingly becoming a bit of a bottleneck, and that we're needing to try and increase our space to review these acute patients. Our acute unit sees 20 to 30 patients on average a day, but we can see upwards into the sort of the mid-30s on a busy day. So increasingly, we're having to think about new models of trying to keep as many of our patients ambulatory and getting a fast turnover through our unit as possible. We also then do have a small amount of acute oncology in reach, which is mainly those who have a known cancer diagnosis, who are coming in often with sort of an unexpected complication of their cancer rather than perhaps an acute toxicity. But that's quite a lower workload for us at the moment, because our admissions policy is very open. And within Leeds, we sort of every specialty sort of operates an acute take of its own. So the only people that really go through the acute medicine take are either true acute medicine patients, the diabetes and endocrine patients, or the elderly medicine patients, and everyone else goes to their sort of specialty specific take. So with that, we've modeled sort of a fairly open policy. So unlike a lot of people who you have to be within 6 weeks of treatment, we're much more open. We take a lot of patients who are just known to have a cancer diagnosis that have contacted us. And we're generally quite open to A&E to help improve bed pressures to the acute medicine team as well. So we do see a lot, perhaps more general medicine presentations than other cancer centres might around the UK. And increasingly, like I say, in the pandemic, we've been sort of trying to offer more support and taking as many patients off the acute medicine team as possible as well. One of the areas where perhaps we fall down on is we don't have as many acute oncology nurse specialists as there are in other centres. We do have nurse practitioners who help to run our acute assessment unit, and they do all the triaging via the UConn's triage pathway. They also do a lot of these sort of early workup of patients when they first arrive. But our unit is still very much a sort of a doctor-led unit at present, but we are trying to increase our sort of our CNS and clinical practitioner level staff. So we currently have 1 full-time acute care practitioner, and we're sort of aiming to increase that to another 2 trainees in the next intake in the summer. And we've also got another trainee who's just finishing training. So we're going up sort of 4 trainees, well, 3 trainees and 1 full-time qualified ACP at the moment as well. We also then do have support from the haematologists on our assessment unit as well, and they do have all their admissions come through the unit as well. And again, they have their own dedicated staff that help with those patients. So in line with the new curriculum, we've been trying to think about how we might be able to improve registrar training and registrar exposure to acute oncology. And one of the things we're looking to bring into place from August is a dedicated acute oncology registrar role, with an idea being that all trainees will rotate through that role on a weekly basis, so that the aim is they'll do an acute week every sort of 4 months, and hopefully then they'll be able to show that sort of dedicated improvement in their confidence, to demonstrate those capabilities in practice, and also to demonstrate progression through training as well. And that will be an additional role above and beyond those that were already being fulfilled by our medical and clinical oncology registrars on call. So it means that the acute oncology registrars aren't going to be being pulled into the day treatment unit to see people on chemotherapy. They're not going to be being pulled into the radiotherapy unit, and they're not going to be taking cord compression referrals, because our clinical oncology registrars are the cord compression coordinators for the region. So it means that they're going to be freed up to focus purely on those patients who are either acutely presenting to our unit and being able to help manage those patients and help to oversee the senior oncology take, because at the moment our assessment unit is mainly staffed by foundation and core level trainees, but also they will be able to hopefully then develop a bit more of the service. They're going to be doing some more in-reach work. They're going to be doing some work with the cancer and primary teams, and hopefully a part of that role will also be involved in education, both to our own trainees within oncology, but also reaching out to those perhaps working in the other medical specialties across the trust as well. The aim is also that we're going to have a bit more of that front door triage going on and front door assessment. So rather than patients sort of being admitted to be worked up, trying to do a bit more right at the front door as soon as they arrive, and trying to avoid admissions by increasing our ambulatory care models. And along with that, because we're going to be increasing our numbers of advanced clinical practitioners, working how we're going to share those roles across the registrars, but also those who have sort of specifically trained in an acute oncology role as well, so we can sort of mutually learn from each other. And I think really the future of acute oncology in Leeds is sort of looking at increasing the education and training for people, both in terms of us improving the education that we can give to others in terms of the importance of acute oncology and the role it plays in the acute patient management, but also thinking about how we can educate ourselves and better improve our ways in managing these patients. Ideally, we want to be sort of stimulating the registrars for more interest in more senior roles going forward in their career and looking to perhaps take up consultant PAs with acute oncology, but also giving them some dedicated time for service development and improving our potential for audit and research in the future to help to sort of define and devise new models of acute care that we can deliver through a cancer centre. And then we also want to be inspiring our current consultants to also take a more active role in acute oncology. And it's one of those things that I think, because people are very focused on tumour sites, it can sometimes be difficult to engage consultants in the importance of the acute oncology work, but actually trying to sort of demonstrate that enthusiasm and excitement can also help to sort of feed upwards to the consultants to bring people back into the excitement of the acute take again. And finally, we want to be working on our patient feedback to make sure that actually we're getting our patient-centered care correct, because whilst we're trying all these models of keeping people out of hospital and turning them around quickly, we need to make sure that that's appropriate and acceptable to the patients that we're treating. So that's our plan for the future.
So we'll move on swiftly to our next speaker, Naomi Clapworthy. So she is an acute oncology nurse consultant and lead for supportive and palliative care at the Northern Devon Healthcare NHS Trust. Naomi is also co-opted board member of the UK Oncology Nursing Society. This evening, she'll be providing us some insight into the delivery of acute oncology in a district general setting. So without further ado, Naomi, over to you. Please go ahead and share your slides.
Thank you, Dan, and thank you for the invite this evening. I'm going to talk to you about an acute oncology service in a district general hospital. So I work in sunny North Devon. This is my hospital in the middle, and pictures of our lovely beaches and activities that you can do whilst you're here. It's a lovely place to live and work, and that's my little plug just in case anybody does want to move to the area. So as a trust, we cover a huge geographical area all the way down to North Cornwall. In the hospital itself, we do not have any oncology or haematology designated wards. So if patients require an inpatient admission, they could be on any ward in the hospital and would be under the care of the admitting team. We have joint working with Royal Devon and Exeter Trust, so oncologists and haematologists visit on a daily basis, Monday to Friday. Our acute oncology clinical lead is a clinical oncologist who has oversight of the service and is a great source of knowledge and support, encouraging continual development of the service. This is our fantastic AOS team. It's grown quite considerably over the years. We were shortlisted for a HSJ award in 2020 in the Cancer Care Initiative category and nominated for a parliamentary award this year by our local MP in the emergency care category. So we started our acute oncology service in 2015. We worked Monday to Friday, 8 till 6, with 2 part-time nurses and a part-time administrator. We were heavily supported by our staff grading consultants for the first 2 years that this was in place. It was very medically led. We were a new service, and to establish ourselves within the trust, we needed ward teams to understand what we did and the support and expertise we could offer. Our consultants could see the value in us and the service, and they invested their time to support us in practice, developing our skills and knowledge to support the service going forwards. We started on our Masters in Advanced Practice pathway, and over time the service has grown to now being a very valuable and respected service within the hospital. We now have 5 clinical nurse specialists in post, 1 assistant practitioner and a full-time administrator, and myself as nurse consultant. And we now provide a 7-day service within the trust. We are a nurse-led model, but well supported by our consultants and staff grade. I cannot stress enough how important your administrator is within this service. Data is key to service development. It's very clear the positive impact this service makes to patients, but by collecting the data, it will support you to continue to develop the service. We are based on a chemotherapy unit and have access to 3 side rooms. So if patients need to be reviewed, we can bring them in straight to assess, treat and formulate a plan of care. We can admit straight to a ward if we need to. We also manage the 24/7 helpline in working hours and out of hours. Our clinical site team, who are the most senior nurses in the hospital, manage these calls. We complete daily ward rounds to review all inpatients and aim to shorten the length of stay for our patients. We started a trial of our 7-day service in August and November last year, and we saw a 40% reduction in length of stay for our oncology patients during this time. So you can see the benefit of having a 7-day acute oncology service in place. After we review, if we feel a patient needs a senior review on the ward, this will be escalated to a consultant. There is also always a consultant on call 24/7 by telephone, and we encourage that they are contacted out of hours if needed by ward teams. Our team also manage the cancer of unknown primary patients who are often very complex and require a great deal of input and support. We've established a nurse-led paracentesis clinic. This was due to a lack of permanent staff grades in post and no one being able to perform this procedure. Patients were often admitted into hospital for the procedure overnight or even travelling to another hospital for the procedure. So this service has benefited the patients hugely. We also provide a huge amount of training and education as a team across the trust. We deliver daily teaching sessions on the ward and do bite-sized teaching. We do junior doctor training and grand rounds. We also hold cancer-linked professional study days across the year, and this is open to all staff to attend. And these days are very popular and the feedback from staff is very positive. We will basically talk to anyone that will listen, and I think actually this is really important. The visibility and being approachable is so important. As a service, we use the UConn's Triage tool to assess patients on the phone. We follow the UConn's Acute Oncology initial management guidelines, which are now accessible via an app, which is really great to use when on the wards. Our challenges initially were definitely lack of staff grade cover. This was often variable. We had a lot of locum support, but this was often only for a few months at a time. This became quite challenging, and our consultants recognised this and supported us to develop our nursing team to create a nurse-led model, but with continued consultant support. However, the consultants are not given allocated time within their job plans to support AOS, and it is often seen as an add-on to their day. So our consultants are often staying extremely late if patients are needing to be reviewed on the ward. This does need to be reviewed going forwards, as this senior level of input is needed and should be within job plans going forwards. As I reflect over the past 6 years, I am aware that the service would not be in the position that it's in without the support of our consultants. They really helped to drive the vision forwards and ensured that other healthcare professionals within the hospital engaged with us as a team. We do not have oncology trainees within our DGH, which is something that I hope will change over time, especially as we merge with Royal College of Radiologists as a trust. Acute oncology services are often set up quite differently in each trust. I speak to lots of people regularly all over the country, and I'm always quite surprised at how differently they are set up. But I believe that having experience within different settings will only add value to oncology training. I have also been told that we have a lack of medical oncology posts generally in the Southwest, which hopefully will also change in the future. We've had lots of developments within our service, as discussed, our nurse paracentesis. We now have a CUP lead, an immunotherapy CNS lead, and our CNSs are on our master's pathway, so hopefully will develop into ACPs in the future. Our 7-day service started in 2020, and we are hoping to properly establish an oncology SDEC alongside the medical SDEC in the future, as we have outgrown our units. It would be great to have oncology trainees experiencing this model in the future, being supervised and assessed within a nurse-led service. In summary, acute oncology is an essential and valuable service for our patients, and it is a real privilege to be in a service that makes a visible and positive difference to the patient's pathway. Our service works as well as it does because we work as a team in constant collaboration and discussion, and a real respect for our capabilities and skill set. Thank you. I hope that gives you further insight into acute oncology service within the DGH.
Thanks, Naomi. In the interest of time, we'll move on to our last talk. So our final presentation will focus on multidisciplinary team working within acute oncology services. This will be presented by Dr. Catherine Mitchell, consultant clinical oncologist and lead clinician for metastatic spinal cord compression, acute oncology, and carcinoma of unknown primary, with Lindsay Warbank, advanced specialist practitioner in acute oncology, both from Lancashire Teaching Hospitals NHS Trust. So Catherine and Lindsay, when you're ready, please go ahead and share your slides.
Right, I'm here. Thank you very much for the introduction. Here, socially distanced with Lindsay, and we're here to represent the acute oncology team here that have worked very hard to start our hot clinic service. We're based in Lancashire. The network region here is about 1.6 million for the radiotherapy service. We've got an oncology ward with 28 beds, and we're treating about 2,500 patient SAP treatments a year, which hasn't really changed during COVID. We've managed to prioritise our oncology patients. So back in 2017, before we started the hot clinic, many of you will probably relate to this, the chemotherapy unit, you know, patients would just save up their symptoms and wait until they came to see you. And sometimes as the oncology registrar on the unit, it was great in that you were seeing anything that walked through the door, but you often felt like you were a GP for the oncology patients. It was putting a lot of stress on all the teams and adding to stress elsewhere. It became very clear we needed to develop a service for these patients. So we came up with the idea of the hot clinic, and this was very much a team approach. It took a lot of effort from the team, you know, to develop the steering group and the vision. Lindsay did a lot of work developing the background data to support the vision. You know, she got some data to show that, you know, of the patients we were seeing about 140 a year through the chemo unit, and about a quarter of them actually ended up needing admitting. So there was a clear benefit of a need for the trust, but also we were going to have to develop a lot of pathways and protocols, and also train our acute oncology team so they could manage all these patients. So obviously we've got the UCON's pathways, which are fantastic. We work very hard to develop our own protocol. In particular, a lot of our patients seem to be coming in with low magnesium. Lindsay's worked amazingly hard in developing a low magnesium pathway, and she worked alongside the pharmacy and nutrition team, and also with interventional radiology to develop our paracentesis pathway. There was a lot of upskilling needed with our CNS team. They're all working towards an MSc in advanced clinical practice. A lot of the acute oncology consultants here, we mentorshipped a lot of our the nurses, a lot of the team through the medical prescribing course. Some of the team needed clinical skills refreshers, and we worked with radiology so that everyone could have radiology requesting rights as well. We recognise, you know, that, you know, we needed a whole team approach to reviewing these patients. It couldn't just be the acute oncology specialist nurses. So we actually have our trainees timetabled to cover the chemotherapy unit, which they had been doing, to be fair, beforehand, but to help with the hot clinic and more let them focus on more of the acute presentations. So our STs are now working very closely with the CNS team, a lot of the presentations, Lindsay will come on to, the team can manage themselves, but some of the more acute oncology presentations that we're seeing, we're learning how to manage those and focus on which ones need admitting, which ones can we safely discharge. So it's been a really good role, some education for the CNS team, but also the CNS team educating our trainees as well. I'm going to hand over to Lindsay, who's socially distancing over here.
All right, so this is our oncology hot clinic. As you can see, it's only quite a small room, but there's one bed and 2 chairs in there, so it's just showing that. This is a graph showing the number of acute oncology hot clinic attendees in the last 12 months. When we first started off a hot clinic in 2017, we were probably seeing around 60 on average, but as you can see over this last year, our numbers have increased into the 90s, and that has continued over the last 4 months of this year as well. Whether that's the impact of COVID or not, I'm not sure. But these are the number of patients that have been seen by a doctor in 2020. So as you can see, we still need input from the oncology registrars, especially with the more complicated cases, especially with the immunotherapy patients. This is a graph just showing demonstrating the reasons for visits. Obviously, there's quite a lot of numbers just attending for other or bloods. These are not just blood tests. These may be the hepatitis blood tests that need doing, or for the nephritis. And the other is a variety of different things. People coming with epistaxis, the incidental PEs. So on future audits, we have split these up to make it a little bit more easy for auditing to identify why patients are coming through to the hot clinic. And as you can see from this slide, this is just demonstrating the outcome. So as Dr. Mitchell's previously said, we prior to the hot clinic, we've seen about 140 patients a year and admitting a quarter of them. Our numbers have now reduced, so we're seeing probably nearly 800 patients a year, and we're only admitting 10%. So just showing that we are helping with admission avoidance.
So just an example from the other week, I had a 78-year-old patient with pancreatic cancer who actually came in on our paracentesis pathway to our interventional radiology day unit. He was clearly not well. There wasn't much fluid to drain, so he came up to the hot clinic. There was concern that he was in subacute bowel obstruction. The team were able to see him. I actually came down to see the patient. He was desperate to discharge home. This patient would no doubt, he would have been admitted if it hadn't been for the hot clinic, but we were able to get him home with anticipatory meds, contact the palliative care team, and we avoided the admission and met that patient's needs. Another example, quite a few of our patients on immunotherapy would often end up in hospital, especially during COVID. We're very keen to avoid this. So by having the hot clinic, we can bring patients to the unit where they get data review from the team and also the registrar and the consultant if needed. And we can actually give outpatient IV methylprednisolone if required and avoid admission. The feedback from the patients has been lovely, and more importantly, they feel that having the hot clinic there has avoided them going to the GP, so reducing pressures on GP and being admitted to hospital. The chemo team have felt very supportive because often patients will just turn up on the chemotherapy unit. Now having the acute hot clinic on the chemo unit supports them and takes the stress away from those from the chemotherapy staff. And providing that service for the patient, and more important, and also the doctors have noted that a lot of the problems we see the acute oncology team can manage, but that anything can walk through the door. So as a trainee, it's fantastic in that you never know what disease that you're going to see next, and you can focus with the acute oncology team. You can focus on those presentations, and it's good to keep that exposure to the range of cancers. We're not perfect. Our room is too small. It's one nurse by themselves. We could do with another nurse to help. It does get busy. If a patient's been admitted, sometimes the team end up staying late, but we're working on that. But this has been going on since 2017 now, and the hot clinic's well embedded in practice. We managed to prioritise the service throughout COVID, which we're very proud of, and there's been a clear benefit to both the staff and the patient, but also in terms of education for the CNS team and our oncology registrars, and it's very much been a team effort.
Thanks everyone for those really important insights. I think we're often quite siloed in our centres and often regions, and I think it's quite difficult to fully appreciate the variation in service delivery around the UK. So we're now going to have some panel discussion. Appreciate we're a little bit over time, but please stay with us for the next 10 minutes and we'll try and answer some of your questions as much as possible. I'm going to hand over back to my co-chair, Dr. Ruth Board, at this point to address some of the questions that we have come in. So if the rest of the speakers could turn on their videos, and we'll hopefully have some questions and get you all to contribute. Thanks.
Great, thanks very much, everyone. I mean, I think what appeared in the chat, Andy, was that you were saying that you maybe admit more like 50% of patients at Leeds, whereas it's only about 10% at Preston. And I think that shows the difference between, I think we've worked to an ambulatory care model, and if it's obvious the patient's going to need admission, we don't see them in the hot clinic, whereas yours may be more of an admissions unit. And I think that's a really good demonstration of kind of all the different models that you can use to support the front door and GPs surgeries. Is there, at Leeds, do you have a sort of an ambulatory care model as well?
We do. I think it's slightly simplified to say that we admit 50% because there are a lot of day attenders. It's those people that really are sick and need more input would tend to come in and stay in, but there's lots of to and fro in terms of seeing people, turning them around, sending them away. So it depends how you slice it up. But compared to the model that was described from a DGH perspective, we get 7,500 attendances a year into the oncology assessment area. So it's the same problems but on a different scale.
Mm-hmm.
And I think we do have some ambulatory potential that doesn't come through the assessment unit. So our blood transfusions, our magnesium infusions and various other things will go directly to our supportive care unit, which is a nurse-run unit with some medical input support. So we have a completely separate unit where some of those ambulatory patients go as well. So our patients that are coming for acute assessment are much more those presenting sort of unwell rather than sort of perhaps having the slightly more semi-elective stuff done that perhaps other acute units see.
Ernie, can I come to you? I think what we've heard a lot from tonight is some really innovative ideas, some different ways of working, just really demonstrating that one size doesn't fit all and it depends where you work and what staff you have. But I guess what we really need is a way of sharing some of these resources so that we can share ideas and protocols. And I know the UConn's Acute Oncology interest group does a lot of that through the nursing side. Can you tell us a little bit more about the Acute Oncology Society and how that might help us provide those links to people and help share good practice?
Yeah, thanks, Ruth. I think good acute oncology is almost by definition multidisciplinary. And we've heard some fantastic innovations about oncologists delivering oncology-specific pathways. But to really fix the wider problem I touched on earlier, we do need to recognise that it's more than just oncology centres providing ambulatory to their patients within those units. It's about how we reach out and support, ED, AMU, GPs, paramedics. And because of that, we feel we need a strong multidisciplinary association that brings all of those components together. And so we're quite far down the road, I'm pleased to say, in establishing a new society, which we hope will be launched in the summer. Part of that society launch will incorporate a website for sharing good practice, sharing protocols, but critically we want to kind of open the doors of the society to everyone in terms of what will become, I hope, an established national conference and a real, I guess, place where we can develop some of the data, the evidence, and underpin what oncologists always do well, which is research evidence for all of these things we've talked about. So yes, we hope and we'll try to encourage everyone to get involved because I think the future is bright if we can all come together under that society.
And where should we look out for more details, Ernie? Is that going to come through the RCR and the ACP for the medics?
Yeah, so I think from an information governance point of view, we'd like to welcome everybody to join us. And we're just trying to find a mechanism through the various colleges to get out to all the audience and for them to allow us to use their email so we can contact them and bring them in. So we'll find various platforms to advertise, and we'll just ask everybody to look out for those links as they come through.
Great. I'm just going to bring Francis in because we've heard from Leeds, Preston and Devon, and I don't expect you to represent all of the devolved nations, but why don't you give us a flavour for what's happening in Scotland?
Thanks, Ruth. I think what we found up here is that the curriculum, as Rachel commented, has energized us trying to really develop our services. I think what I'm hoping is that knowing that our trainees have got to get an AOS experience is galvanizing what we've got up here. And actually, particularly amongst the DGHs in Scotland, and particularly some of the remote and rural areas, our nursing colleagues have really already been doing this, but to some extent, and Naomi might understand this, have not been recognised. So what's been quite exciting is we've managed that one of the AOS consultants in Edinburgh has pulled together that group of people. So we're identifying what's out there and trying to bring them all together and try and expose them so we can see where we can put our registrars for training. We don't quite have the number of AOS dedicated consultants up here, and that we really do need to think about. We also need, as Ernie says, to think about data, because data is very much the way to drive a service forward. So all of these are coming together. And I have to say, being involved with the UK energy and particularly the new society, I'm hoping that we can really push that forward. Wales, I think, are slightly more further forward than Scotland, and Northern Ireland we look forward to working with as well. So I do think, obviously for the people of the United Kingdom, it's very important we all work together, but for our trainees, we also need to just take examples, and hopefully my colleagues from devolved nations who I've noted in the audience are here and interested to be involved as well.
Thank you. And Rob, you obviously got a lot of experience in this area, and I know Andy did the presentation. Is there anything that you wanted to add into the discussion from your point of view about the future of acute oncology?
Only in that I agree with everything that's been said, that we need key leadership and we need active engagement around who's going to be involved. But the emergence of those key leaders and that involvement doesn't mean that those who aren't at the front line can dissociate, because actually we're representatives of our colleagues in terms of presenting a patient face in the acute setting when the patients perhaps need us the most, and relatives and carers are facing towards us. And I think that clear understanding of pathways and clear communication from consultant colleagues around where the individual patients are on their cancer journeys is immensely important. Often managing the acute complication of the cancer is relatively straightforward, but understanding that in the context of the patient and where they are with their communication and what they're expecting is much more difficult, and that's where we need input and support from colleagues.
And a question for Naomi and Lindsay, really. The UCONs and the oncology specialist nurses, advanced clinical practitioners and nurse consultants do a huge amount of work within acute oncology and have really helped drive this forward. I think one of the pushback is always, well, the nurses can deliver acute oncology, and working with a number of highly qualified nurses, sometimes I do feel like maybe I'm not needed. So could you just expand a little bit on why a doctor and a nurse together is better than either one on their own? I'll go to Naomi first.
I think, as I talked about in my talk, at the beginning, definitely our model was so medically led and it needed to be. And then over time, and that's through the support of the medical team, we've developed into this it is a nurse-led model, but we do need that medical support and supervision and leadership within our service, definitely. There are many times when there comes a point where I need to escalate a patient to a consultant to get their knowledge and expertise and skill set, and it's working together. And I think for me, our consultants really trust our team, and I think because they've invested in it themselves, and our service just works really well together. But as I've said, it does need investment in terms of support for the consultants, so it's allocated within their time, because at the moment it just isn't. But we just complement each other really well, but acknowledge that we're both needed, but we do need that leadership from the medical team.
And it's a bit mean for me to ask Lindsay, because not only does she support the Acute Oncology team, she supports my melanoma clinic, but I am going to ask Lindsay to just comment about the model and what you think you get from having clinicians heavily involved in the Acute Oncology service.
Well, I can just really mirror what Naomi said, but from a personal perspective, I do think we do our MSc in Advanced Clinical Practice, and we do our clinical skills in 12 months, which the medical students will do over 5 years. So even though we do have a skill set, I wouldn't say it's, perfect. I don't take offence to anybody, but also, like, especially with the melanomas, I bring it to you with all the immunotherapy side, and I find it quite complex with the endocrine issues. So I find it that we do get a lot of support from yourself and the oncology registrars in terms of managing the patients in the hot clinic and on the wards as well, because we know some, but we always need that support, and sometimes we do need to escalate things to consultants for our own learning, to support what we're saying. And also sometimes the medics do want the consultant to come along and see the patient as well and have their input as well. So and as you've said yourself, Dr. Moore, the doctors focus on one thing, the nurses look at everything. So, together we kind of identify everything and pick up all the problems as well.
Okay, thanks very much, Lindsay. I'll make sure you don't get given too many patients tomorrow morning. So I'll just hand back over to Dan to sum up for the evening.
Thanks very much, and thanks for sticking with us. I know we've overrun by a little bit, but it's a really useful session today, and I think some really useful discussion and insights from across the UK. So thank you for joining. We can only provide certificates to those who complete feedback, so please do remember to do this for us. The next ACP webinar session will cover renal cancer, and that's on Tuesday, the 15th of June, our usual time at 6 p.m, with Professor Thomas Powell from Bart's Cancer Institute, based in London, and Dr. Balaji Venugopal from the Beatson West of Scotland Cancer Centre in Glasgow. You can register at www.theacp.org.uk, and that's medical and clinical oncologists, so we'd love to have you on board. On behalf of the speakers and everyone at the ACP and the Royal College of Radiologists, thanks again and good night.